Uh, we are live.
Good evening, all friends from our Maharashtra Ophthalmological Society and All India Ophthalmological Society. Friends, we all know that cataract surgery is now both art and science, and the current generation of cataract surgery has graduated into what is being called as the refractive cataract surgery. Probably cataract surgery is still the most commonly performed surgical procedure on the human body, and what we call as the bread and the butter for all comprehensive ophthalmologists. All of us want to upgrade our skills in cataract surgery in various situations all the time, and we want to give our best to all our patients. So continuing with the tradition of Maharashtra Ophthalmological Society, which is probably the largest state society of India, and its scientific committee, here we bring to you a very unique webinar on the top pearls of cataract surgery by some of the best experts which are known in this field, who are known nationally as well as internationally. And here we have amazing panel of experts and our star-studded faculty today. So basically, I would like to just first welcome and introduce our panel. To begin with is Dr. Colonel Madan Deshpande sir. Dr. Colonel Madan Deshpande sir has been the past president of Maharashtra Ophthalmological Society. He is a doyen of ophthalmology, is a teacher of teachers, and he is the one who spearheaded the uprise and the tertiary care institute that we all know as H.V. Desai Eye Institute. Then we have our past president of Maharashtra Ophthalmological Society and the current scientific committee member, Dr. Parikshit Gopte with us. Then we have Dr. Suven Bhattacharjee, probably one of the most well-known innovators, one of the most amazing surgeons that we all know from Calcutta. He has been extremely inspirational figure to all of us with his new innovations, has taught the world how an Indian can be a great innovator, can be a great entrepreneur, a clinician, as well as surgeon par excellence. So welcome, Dr. Suven sir. We have Dr. Amulya Sahu sir, who is the founder chairman of the widely spread now International Society of Manual Small Incision Cataract Surgeons. He is the one who has probably spreading the wings of this great organization across the world globally, and recently started also a chapter in Middle East as well. And we have Dr. Anaga Herur, our very dynamic secretary of Maharashtra Ophthalmological Society, a great surgeon and clinician, and currently the member of ARC in the Western Zone. And of course, chairing this whole session will be our Honorable President, Dr. Santosh Bhide sir, who is the president of Maharashtra Ophthalmological Society, our very dynamic and a very supportive, great guide that we have in the form of Dr. Bhide sir. And I would like to request Dr. Bhide sir to give his welcome address for today's webinar.
Thank you, Vardhaman. Congratulations to you and scientific committee for this unique webinar by Maharashtra Ophthalmological Society. Good evening, everybody. Welcome to the webinar with a difference, my top pearls in cataract surgery by Maharashtra Ophthalmological Society. I am sure this webinar is going to be a different webinar, which is going to be a video-based webinar. And we at Maharashtra Ophthalmological Society are fortunate to have galaxy of faculties and speakers of international repute. I am sure this will be extremely useful to all of us in our day-to-day surgical practice. And as I have said, Dr. Vardhaman has taken a lot of efforts for this webinar. And without wasting time, let's start the webinar. Over to you, Dr. Vardhaman.
Thank you, sir. So friends, we are very lucky today. As Dr. Bhide sir said, we have some of the greatest minds and the hands as the cataract surgeons who are going to guide us through and give their top pearls. We have some of the best teachers and some of the best guides that we have today. And I think I'm going to introduce all of them one by one when their top pearl videos are coming up. So to begin the session, first, I would like to invite Dr. Kumar Doctor. Dr. Kumar is a very prolific cataract and refractive surgeon. He is the director of the Dr. Eye Institute in Mumbai. He has been the past president of IRSI at national level, has been in the past also member of All India Ophthalmic Society's scientific committee. And he is also the first surgeon in the world to perform the presbyopic LASIK on a pseudophakic patient. So over to you, Dr. Kumar, for your amazing pearl.
Thank you, Vardhaman. I like these webinars because we get to hear good things about us. Thank you, Dr. Santosh Bide, the whole team of Maharashtra Ophthalmic Society. It's an honor to be here. I'm going to share my pearls on how to place an endocapsular ring. I get a lot of questions about this, so I'm just going to show 5 tricks. And it's a short video. I may pause because we have to only present for 5 minutes, and that's what I'm showing here. Hello, friends. These are the tricks and tips for using an endocapsular ring. So trick number 1 is always place the endocapsular ring into the bag through the side port. So never use the main incision. And we glide it along the equator of the bag, and a bimanual technique to place the endocapsular ring into the bag itself. When we have to place an endocapsular ring, remember one thing, always start placing the endocapsular ring opposite to the area of subluxation. So this is very important here, that you can see the area of subluxation is here. I've started placing the endocapsular ring across it, because when the whole ring goes inside, the 2 eyelets will come opposite to the area of the subluxation. So that's very, very important. When the placement of the endocapsular ring is over, the 2 eyelets will come opposite to the area of subluxation. And it gives complete support to the area of the subluxation that is really necessary. Many times the confusion is to place the endocapsular ring before phacoemulsification and nucleus removal. Always place Helon under the CC. So this is about placing the endocapsular ring before phacoemulsification. So it's very important that we can't start putting a viscoelastic from the margin of the CCC till the equator, just below the CCC. So what we are actually doing essentially here is pushing the cortex away from the CCC so that it does not get entrapped in the endocapsular ring. So this is a trick that one can use, and this will 100% succeed. It never fails, because you created the space into which you are injecting the endocapsular ring. Till the equator of the lens. Once that is done, we create the space between the anterior capsule and the cortical material, and then we place the endocapsular ring. Sometimes you need a Sinskey hook to guide this endocapsular ring inside the bag. And once this is done, as you notice, I'm gliding it opposite to the area of subluxation. So when the endocapsular ring is completely in the bag, the 2 eyelets will be opposite to the area of the subluxation. So this is again a Besset's T in the dominant hand, and the non-dominant hand. So this is another trick. What I'm doing is I'm using a T, it's called a Besset's T, through the main incision. I got the eyelet with my Sinskey hook through the side port, and this T will never let the endocapsular slip into the sulcus, because you're holding on to it, and then it just goes behind the CCC. So this is a bimanual technique of placing the endocapsular ring. And this bimanual technique makes sure, and you never fail, that the ring goes inside the bag. Sometimes we find that the endocapsular ring rotates over phacoemulsification. In such cases, under irrigation, we can actually rotate the eyelet, and to make sure that the area of subluxation is completely covered with the endocapsular ring. So here I got my irrigation on the bimanual. I got a Sinskey hook. I'm hooking onto the eyelet and rotating and making sure that the area of the subluxation is completely covered with the endocapsular ring. So the final trick is to use a Besset's T in the dominant hand and a Sinskey hook to glide the endocapsular ring into the bag in the non-dominant hand. Thank you.
All right. I think superb pearls, Dr. Kumar. So basically, so what are the situations where you would actually plan to implant your CTR before you start phaco versus after you have done the cataract removal?
So if the subluxation is more than 180, then maybe I'll need more support. So one way out there is to use capsular hooks, do your phaco, then put an endocapsular ring or a Cioni. If you don't want to put capsular hooks, maybe you can put an Emin segment and then do the phaco and then put a Cioni or whatever. So these are the places where you can think. So here I did in one case where I thought the subluxation was more than about 4 o'clock position. Then I thought I'll take support from beginning only. So I decided to put the endocapsular ring before. So it's very individual cases scenario that you'll see when to put it before or after. But if it's less than 3 o'clock, normally capsular hooks hold on very, very well. I've done even more than 180 on capsular hooks. You put 3 or 4 capsular hooks and the bag is still held on. So it really doesn't matter.
Yeah, I think the tip about using the capsular hook against the iris hooks is very important because they will give you equatorial support that the iris hooks will not give it. I think the topic is open for discussion if any of the experts or the faculty would like to actually chip in and give their comments on the same.
So there is one thing I want to just say is that I have not shown here a video of injecting an endocapsular ring.
Yes.
So what happens is if you use a Madhu endocapsular ring and try to inject it, it will break. So when you are trying to inject an endocapsular ring, you need to use a better quality endocapsular ring, which is more malleable with the help of the injector. So it's quite easy to use an injector also, but this was a technique where you don't need an injector and it never fails. That's what I wanted to show. Yeah, Anaga, you were saying something.
Just a question. Suppose you're putting an endocapsular ring and then you end up having a PCR. What do you do in such a situation? How have you managed in such a situation?
So if it is just a small PCR in the center, you can still put a bag.
But if it's a fairly
PCR,
large,
and you think that it's compromised all over, then trying to fish for the endocapsular ring is extremely difficult because it's gone and sat somewhere. So sometimes if it is not getting disturbed, it may even sit there for years. It may not come down. But if it has started rocking, then it's best to remove it.
To answer your question, Anaga, see, if we are have a PCR, the CTR is most probably in the sulcus now. Okay, either partly or wholly. And there is a paper by Robert Osher which says that it's best left alone, and it doesn't cause any harm unless it's actually hanging down into the vitreous, and which if it does later at a later date, it can be handled. But primarily with the surgeon trying to do, unless the surgeon has got enough VR skills and the equipmentation, it would be very difficult to visualize and kind of get it back. And a touch in the ciliary body could lead to a terrible bleed, and it would be a disaster. A couple of pearls that I would like to add. I think one was Kumar himself used to emphasize a lot earlier was to use the side port for the CTR.
I said it in this.
Yeah, you did say that. Okay, so I missed that. Okay, now there is a very common adage or a statement which was used by Samuel Muscat and has been very popular. Use a CTR as early as you can and as late as you should. Okay, so now that is a big call because soft cataracts, you may be able to put it in early because you got enough room over there. Hard cataracts, you need to create space before you can put it in. So we need to actually, it's a balancing act. It's easier said than done. So we need to see how much space and whether the putting in the CTR itself is going to cause enough torsion and damage more zonules. And depends upon what is the etiology of the subluxation. That also will be a question to address. That's it.
Comment on sizing of CTR, Dr. Kumar.
Yeah.
There are two sizes available, and depending on the lens power, you can take a larger CTR or a smaller CTR. This I'm talking of the Indian ones which are there.
Your tips, please, for sizing of CTR. How to
So
choose
if
it.
it's a high myope, then we prefer to use a larger diameter CTR. Otherwise, if it's a normal case of a 20 diopter IOL, we don't need to worry. So I would prefer to go, say, below 14 diopter and a lower myopia. I'll select maybe a larger CTR. In the other cases, I'll select a normal CTR.
So what I do is I get it from Autolab. So my basic inventory is 11-13. You know, 13 millimeter open and 11 millimeter when it is in the bag. And in certain cases where I notice that it is a small bag, then I go for the 10/12. Pre-order. I don't keep it in inventory, but I order for it.
so on the white to white, we need to decide. And the eggshell length.
I will power, yeah.
I would select from the
myopia and hypermetropia. This is what I take into account. Another thing is sometimes it is useful. I don't know whether Kumar must have mentioned it. Is do a little bit of visco dissection under the capsule, so that you separate the capsule, the cortex, and create some safe friendly zone for the CTR to go in without much trauma to the to the underlying to the zonules.
Yeah, I said that.
Vipurkar sir wants to comment on CTR something.
Yeah. See, with the kind of CTR that we use in our country, that material is very soft. And we believe that the memory is not lost, but with the ECRs, when you remove them years later, the memory is totally lost. So if I have no fuss about the length, in fact, I have a longer ECR and I'm better off because in a small eye, the ECR will overlap. To that extent, in the area where I need maximum support, I may even intentionally overlap the CTR. So Whether it's small or big, it doesn't matter. If it's big, you get an additional advantage.
And
You
another thing
prefer
I've
big
noticed with the
for all.
Indian CTRs is that the eyelid diameter is not standardized. So sometimes when I use the goiter injector, the hook of the injector gets stuck to the eyelid. Sometimes it even gets stuck to the Sinski. So I always have another Sinski available in case you find that you're not able to release because the eyelid was smaller than what it normally is.
Right.
Any preference of Indian CTRs by panelists, esteemed panelists,
Has anybody like
and faculty?
Madhu versus Orolab versus others?
I've used only Madhu.
See, Madhu ones are softer, and the PMMA is different in Madhu and the Oro and Appa ones. Oro and Appa ones are a little stiffer. So it's a personal choice again. One thing I would like to add, some of us have the habit of, in the way, like Dr. Kumar showed, using a Hirschman hook or a T, you could guide the CTR. Some of us use a 23 gauge forceps through the side port to hold the eyelet and tuck it into under the capsulorhexis margin. And I would like to caution everybody that do not, if the CTR is kind of pushing against that forceps, please do not let go that eyelet, because if you let go and the jaws are open, it just comes and gets stuck. And it gets wedged just gets wedged in that jaw, between the jaws, and then it becomes a very embarrassing situation. You can't get that eyelet off, and you can't take that 23 gauge forceps out of the eye.
I just like to add a point. I think one easy trick that we've been using in our clinic is to thread the CTR with the 10 nylon when we implant it, because I've lost a few and I've been very, that nylon has been like a, rope that helps you in retrieving the CTR at times of crisis. So at least I'm doing it for all my cases. But at least for the early surgeons and for the residents, it's important to, at least attach it somewhere so you don't lose the CTR, because once gone, it's gone.
Yeah. So in the event of like PCR, let's say that you don't worry about losing it.
You can just retrieve it out. You can just pull it out.
Yeah,
So Deepak, you want to add something?
Yeah, just a comment on the Madhu versus the Oro. As everybody told, Oro is slightly rigid. The eyelets, as Arup sir was telling, they're not standardized. The Madhu ones, the eyelets are slightly bigger. The Orolab, slightly smaller, but the Madhu has now introduced a preloaded CTRs, and which I have used a few of them, and they seems to work well. They have two ones, the one which opens to the right and one which opens to the left side. Of course, no financial interest, but definitely they are much more softer than the Oro ones. So if you decide if you want to have a much more strength, I would prefer Oro CTR compared to a Madhu CTR, where your primary intention is to the memory should last long, as Haldipurkar sir was telling. So we have got two choices here, and the design is different, material is different. It's good now. We have got better choices nowadays.
Interesting. So I think Madhu is softer and the Orolab is the stiffer.
Yeah, this is my experience.
Oh, good. Yeah. Super. So anybody else would like to add any comment on this topic of CTR while we are there?
I have had cases long ago in the past when this injector, the spring system mechanism misbehaves, and the CTR does not get released in the way in a circumferential pattern. So it goes straight, hits the fornix, and then it reverses, takes an S shape, and then it goes to the fornix. And sometimes it stretches the rhexis margin so much that in one case I had a rhexis margin tear. So then I realized it was two cases happened subsequently, consecutively. So I got it repaired. It was actually some fault inside the injector system. So that got repaired and it became all right. So if you feel that your CTR is not moving smoothly, there's suddenly some resistance that is coming up, particularly if you have those capsular hook, not the iris hook, the capsular hook, or sometimes even a routine case, if certain additional resistance, I think you should be a little cautious and try to look into it, what exactly is going wrong before it is too late.
Great. I think like very good inputs from everybody. So I think maybe the last question, if you are given a choice about manual insertion of CTR versus the injectable ones, what would the faculty choose here?
Now the injectors are very good, Vardhaman, compared to the many years back. But I mean, with experience, our manual is so simple anyway, it's so easy that we don't need to make that extra effort. I have broken one or two CTRs loading it into the injector, but as I think Deepak said that this was the old one. So the new which are preloaded must be much more easier.
then one only extra step you have to learn is to release it from the hook and make sure that it goes into the bag. So that's the only one extra step that has to be learned. So I think it's availability and convenience and maybe costing, because a normal manuals really is the cost of the CTR, which we know is quite cheap.
I don't think they come pre-loaded as such. You need to load them and then inject them because.
No, preloaded available now. So when?
Yeah, it
okay,
comes
sir,
preloaded.
Madhu has been sending a lot of advertorials.
Yes, yes.
They're there
And
available.
if we are using this, these metal injectors, Goiter and Rumex, this is what I inject. There can be a collection of debris within the substance of the, so that is something which I was not aware till I saw it happening, and they have to be cleaned promptly. Whatever the dried OVDs or whatever, immediately it has to be cleaned up. Otherwise, you will have debris coming out of the injector tip along with the CTR.
So once I tried a Goiter injector with a Madhu ring, and I got a different shape of it. So it doesn't work. So it's just a thought that the PMM is different. So it is not as malleable as the other ones.
Great. So great. I think we had amazing discussion on this CTR, and we definitely learned a lot of new things. I think definitely many things were not known to most of us before. So I think probably thank you so much, Dr. Kumar. Amazing pearls, and thank you to all the faculty for their own pearls as well. So I think over to Dr. Bide sir for introduction of the next faculty.
Yeah. So we have next faculty, Dr. Suhas Haldipurkar. He's a founder director of Lakshmi Eye Institute and founder and chief trustee of Lakshmi Charitable Trust, which is a recognized center for postgraduate training, DNB, and also surgical training. We all know that he's pioneer in phacoemulsification in India, not only in India, but he goes to Austria for training in Winter Academy for last 18 years. We all know that he has received many awards, and he was awarded with Certified Educator Award from Asia Pacific Academy of Cataract and Refractive Surgeons. He's a great surgeon, teacher of teachers, great human being. So over to you, Haldipurkar sir, for your
Thank you so much.
top pearl in cataract surgery. Yeah.
Thank you so much. Thank you. Is my screen visible, sir?
Yes, sir.
Yes,
Yeah.
sir. Yes, sir.
So, this case, I'm going to speak about management of cyclodialysis cleft using the different technique than what we are used to. There's some problem here.
Okay.
It's a new approach. Cyclodialysis cleft is a separation of the ciliary body from the scleral spur, creating a direct connection between anterior chamber and the supracaudal space. This patient presented with progressive painless blurring and a history of trauma to his eye 7 years before. He had consulted elsewhere and was diagnosed with retinal issue, and intermittently he was on prednisolone and homeotropy. When he presented to me, his visual acuity was counting fingers 3 meters. His applanation was 4 millimeter of mercury. Slit lamp showed traumatic mydriasis with NS2 and diffuse PSA. This is how his gonioscopy picture showed the cleft. And the UBM reports revealed a cyclodialysis cleft at 2 and 7 o'clock position along with right-sided circumrotation of ciliary body processes. The standard treatment protocol is for less than 4 o'clock hours. Medical management is tried with cycloplegic agents like atropine for 6 to 8 weeks, steroids, and laser photocoagulation, including endophotocoagulation. But when you have a cyclodialysis which is more than 4 o'clock, surgical management is normally used, which is direct cyclopexy through partial thickness limbal scleral fluid, encerclage or cryotherapy sometimes, even continuous ab interno repair. These are some of the pictures of how contemporary approach, which is quite extensive, and this again is another one where full thickness scleral incision overlying the cleft, and the tenor polypropylene is used to pass through it. What we tried is something that a cataract surgeon is very much used to. The cataract surgery was the normal, except that I used low IOP. And once the cataract was removed, there's some issue with it. A 3-piece lens was placed, obviously in the back. And this is the modified Sionis with 2 eyelets. And the conjunctiva was reflected in the site of maxillum cleft. And a tenor double-armed suture was threaded through each eyelet of the Sionis ring. And it was, inserted under the iris to come out almost 1.5 to 1.8 millimeter from the limbus. And the hooks were used to get a better separation, so that when the needle is passed through, you are exactly in the sulcus, and so that your needle can come out almost 1.5 to 1.8 millimeter behind. There's some issue here, so it's I'm just rushing it. See something. And this is a little clumsy when, once the sutures are taken out, then gradually you have to get your endocapsular or this Sionis ring inserted. And normally a ring is placed within the back, whereas here it is placed in the sulcus, where one eyelet is placed at the site of maxillum cleft, that is between 2 o'clock and 7 o'clock. And once it is placed, the sutures are pulled out, and the suture on the site of weakness is tied tightly, and then the second one. After that, the visco is removed and pilocarpine is put to constrict the pupil. And the conjunctiva was, suture placed back with the help of glue. And this patient was instructed that in case he has any difficulty at night or pain, he should immediately report back. And as expected, on the first post-op day, he came with IOP that was unrecordably high. Corneal edema was present, and there was pain and discomfort. His anterior chamber paracentesis was done under aseptic precautions. IOP post-paracentesis was 28 millimeter. He was put on prednisolone, atropine, gatiflox, and anti-glaucoma medications. He was called on post-op day 3 when his vision was 680. His IOP had come to around 24. He still had hypotonous maculopathy. On day 12, the situation was practically sane. And on day 30, his vision still continued to be 612 and his pressure was maintained at 19. And by 3 months, his vision had recovered back to 6.6 and 6. And IOP was 18 and he was on beta-free. And then 1 year later, he came when he was off medication for IOP. His vision was 6.6 and 6. But he had a pupil which was horizontally oval and slit-like on one side, that was on the side away from the weakness. And that's where his iris was stuck into that Sionis eyelet. So it was not possible to do pupiloplasty unless I cut that eyelet. So I had to go back in and cut one eyelet. And with that, the iris was released and the pupil became quite circular, although he had pre-op, post-traumatic metriasis. So from this, the pearls that I took home is that ring or modified ring are the easy alternatives for closing the cleft. A regular Sionis ring with single eyelet is probably better than modified Sionis ring with 2 eyelets. Ring should be sutured on either side to avoid forward shifting of the ring. First you tied on the side where the weakness is, and you also have to tie on the other side. Otherwise, it shifts forward, and sometimes it can push the iris forward. So these were few pearls and an easy approach for a cataract surgeon, because we are so much used to using Sionis ring. But normally we put these rings in the back, but here to close the cleft, you have to put it in the sulcus. And suturing part is little clumsy because there's too much of things happening. So first you get the sutures in properly, pull them out, and then enlarge the opening, because if you have done phaco with 2.2 or 2.4, the Sionis ring will require around 2.8 to go in comfortably. So enlarge it even before you insert the sutures. And once the Sionis ring is in, you position it in such a way that single eyelet is placed almost at the site of cleft. Suture it first and then suture the other part of the ring. Thank you so much.
Amazing. So extremely innovative solution, sir. And of course, we all know that it is a rather rare thing to see. So in your entire career of spanning more than 3 decades now, how many this cyclodialysis clefts have you actually encountered, and how has been your experience with the previous techniques?
This is probably the only one which I had to tackle, because most often, when they come, there are multiple specialties who kind of treat it. This patient had cataract and he had come for us, and then we accidentally noticed that this was the cause, and so we thought might as well try something that was innovative, because otherwise most of the things are done by retinal surgeons.
Right. Yeah, sir. But I think you found a rather simple solution to a very complex problem. And whatever I think I have seen so far in the literature, the success rate has been rather low actually for cyclodialysis cleft. And here achieving 6/6 vision, a complete resolution of hypertonic maculopathy was amazing.
Just 7 years he had this. That was very surprising.
Very lucky actually. Any of the other experts would like to comment anything? Dr. Bide sir, anybody else?
Yeah, KK Mehta sir, you want to comment on this?
No, I'm just amazed at how beautifully he's handled it.
Dr. Gokte sir, I think he wants to
Yeah,
add.
I mean, we have seen very fantastic surgeons operate, and Dr. Adip Pukar is the best, one of the best globally. And we are sitting amongst so many great cataract surgeons. But this is something that we learned as surgery first in intracapsular cataract extraction. And suppose if the subluxation is slightly large and we don't want to put in a multifocal lens, then isn't it simpler that instead of doing all the rings and everything, you just remove the lens along with the bag, and then you put a scleral fixated lens or a iris claw lens? Or, does it make, this is something I would want to ask Adipurkar sir, Dr. Mehta. Does it make a very great difference in the patient's vision in the long run and the safety in the long run?
If I have to reply to you, Parikshit, I would leave no stone unturned to preserve the capsule and get the cataract. Very often, even when there is very extensive pseudo exfoliation, when I know that bag cannot be fixed, I would still hold that bag there with the hooks and get the cataract out, because in the process of getting the cataract out, I somehow do not want to disturb the anterior vitreous. And if possible, see, there are several instances where I would use an endocapsular ring to keep the bag there. Sometimes I may even fix the bag there, but I will use iris claw lenses so that I don't take the support from there. Even to that extent I would go, but I would not want, if I can avoid anterior vitrectomy, because you just can't do that. The moment you do vitrectomy, there's a whole lot of other process that goes on, and your retina is definitely exposed to some long-term risk, which I would like to avoid. That's it.
Keeping the bag is very, very important, sir. I mean, even if it may not perhaps support the lens.
Yes.
It's
Also,
more
I'm
like
guessing if you
keeping the barrier safe, because the barrier is essentially what protects the macula in the long run.
Yes.
Also, with the cleft lying and doing a vitrectomy, because your choroid is, the ciliary processes are anyways hanging around, you might chew up a bit without knowing sometimes, because if you don't know the extent of the cleft posteriorly, how far it's going. So, but this is a great idea. I think more important than the diagnosis of the disease is to come up with an idea to put a CTR, like a Cioni ring in place to be able to tamponade the area of the cyclodialysis. Brilliant idea.
And what else I felt after 1 year when I saw him and saw a slit-like horizontal pupil, that's when I knew one big mistake I'd made. I thought I would require a double arm. It's a double eyelid. You don't need, because even a simple ring can also be stitched into the sulcus. And if I had done that, at least the pupil, I wouldn't have to go second time again, because what I did second time when he came, I went in with the two instruments. I just snapped, because that eyelid cannot be, it's PMMA, and your micro scissors cannot cut that PMMA. You have to just snap it and take it out. The moment you took it off, the pupil came down.
Actually, I was going to just ask that because when you're using a Cioni eyelet, the pressure on the ciliary body or where you want it is actually a little indirect. You are, in fact, if you use it directly on the ring, if you tie a suture and I think it's compressing, it's much better, what you want to achieve.
Yes.
So that part of using a Cioni single or double was actually probably, I think that's from your hindsight, we learn.
Yes. I realized that maybe a single, just a ring would serve the same purpose better.
Maybe even a larger ring without a suture.
No. That PMMA ring, I have realized that it won't give you that kind of outward pressure. You have to suture it.
Has to be very rigid. Yeah, great. Thank you so much, sir. I think it was a great innovation and great learning pearl for all of us. Thank you again. Thank you, sir. So now we have the doyen of Indian ophthalmology, Professor Dr. Padma Shri K.K. Mehta, sir. He is going to talk to us about his pearl. We all know, I think Dr. K.K. Mehta, sir, requires no introduction. He has been the past president of All India Ophthalmic Society, has been the past chairman scientific committee of AIOS. He's the one who runs the advance, and this is the 25th year this year. So congratulations, sir, for a very successful international meet that has been going for decades under your amazing leadership. And over to you, Dr. Mehta, sir, for your top cataract pearl. Thank you.
Sorry.
Yeah, no problems. Take your time.
I'm going to talk on something which is quite different. Over a period of time, when doing phacoemulsification, handling hard cataracts, if the cataract is very hard, we always say that it is better to open it rather than taking a chance of damaging the endothelium. And over a period of time, when I started using the Milo, I discovered that it makes life, especially phaco, very much easier. Let me talk to you a little about it. I'm first going to just introduce it, and I don't know if all of you are well aware of the ring, but essentially the whole problem with super hard cataracts is that you need to have something which can protect the endothelium. And the little device, which is the Milo, but is made by Zeiss, I have nothing to do with it. Unfortunately, the Zeiss hasn't even given me 1 unit free after all the numbers which I've used. Essentially, it is nothing much more than a little ring. Now, all of us have used this wire ring earlier And we keep asking ourselves, what is so great about it? The difference between this unit and what we have been using up to now is that when the loop opens, it opens in the shape of the lens, which is really one of the big advantages. Essentially, it's the loop made of nitinol, opens the maximum width of 1 millimeter of, the maximum width of 1 millimeter, opens to 10/6, opens very smoothly, and big advantage is it reduces phaco energy, protects the zonules, reduces procedure time. But let me show you really what it is so that you know what we are talking about. First, I'm just going to show you a baby case. My talk really is on rock hard cataracts using the Milo. And I was just showing you a baby case so that you get an idea as to what really needs to be done. Essentially, the rhexis, when you use a Milo, should be a minimum of 5 millimeters in size. It can be a little smaller and get away with it, but I would advise you very much, keep it a minimum of 5 millimeters. This is if you have a rock hard cataract. You insert the Milo, putting it inward, put the edge, and then just simply expand it. As you will see, the ring expands out comfortably all the way around. And as you turn the Milo, you will see the shadow of the ring moving in. Let it cross the horizontal plane, take it back, and then simply cut your lens into two. Advantage of doing this procedure is that irrespective of how hard the cataract is, two pieces come immediately, and as you are removing the ring, you have to rotate it horizontally and remove it. Once you take it out, then doing phacoemulsification is simple because you got two pieces, out of which one of the pieces will come out. You can notice the sharp edges of the cut edge, indicating that it cuts cleanly with no problems at all. Interestingly enough, when we first started utilizing it, I was always worried that am I going to land up one day with a vitreous sitting in my lap and everything going in when I cut it. Now let me take a few rough cases so you can get an idea of how it runs. You had a hard wide cataract. Can't see anything through it. Open your loop up, swing it round. It'll go peacefully under the bag without a headache or a hassle. And even if the cataract is quite dense, you will be able to still make out a little of the loop swinging in. When you cut it, the cataract cuts into half. Again, there's no problem. So this is a simple method which enables you to do phacoemulsification even in rock hard cataracts with complete safety. Please remember to use a repositor to support the lens as you see me doing it from one side. And when you rotate it, rotate the loop out until it comes in the anterior chamber before you remove it. If you don't do that, you may break your capsule. I have used maybe over 100 of these cases. So I've got a little experience, a little more experience on this. Let us take a nice hard cataract now. Similar way, swing your loop around, open it and turn it around. When you turn it around, again, you should look for the little image of the loops below. Harder the cataract, the less image you can see, but invariably the reflection will always be there. Again, hold it in horizontal position, put your repositor over, very important. We don't want the lens and the loop jumping. So this supports it. And then you simply cut it into two pieces. Again, the moment you cut it, you can notice the sharp edges as it cuts, indicating that the cut is clean, absolutely no hassles and no difficulty. Turn it and take it out. Again, now, if you have already put in hooks and you have a tough case, can you still use it? Yes, you can. Irrespective of whether the hooks are put in, my loop will still slip in just as easily. You can use it, swing it around. Here you will notice it tends to snag a little. Don't be in a hurry. Move it a little forward, a little back, juggle it a little. The hook will gradually, the loop will slip into place behind. You are waiting to see that little glow, which tells you that you have reached the point which is more than the halfway line. When you reach that place, you can, now this is a hard cataract, so you can notice that the glow of the little loop is not really visible. Same thing again, put your repositor on top and you cut your lens into two parts. This is a hard brown cataract, but it makes no difference. It's irrespective of the density of the lens, it just cuts in fractions of a second and you can take it out again. Now, there are various ways in which you can handle these things. But one of the things you have to remember is you must be sure that your loop slips under the capsular bag. Please be careful about that because sometimes you tend to put it on top. So make sure that the loop goes in cleanly and make sure you can see the little glow as it runs. Once you see that, then the cutting is very simple. It cuts into two parts. Hard cataract, soft cataract makes no difference. Everything just cuts into little bits. Again, sometimes it's not as easy, but let's take a look at a rock hard cataract now. A hard brown cataract, and here we slip your loop in and expand it. Sometimes in these rock hard cataracts, the loop will have a little difficulty slipping backwards. Don't be worried about it. Just hold it in place and juggle it a little. Move it a little left, move it a little right until it gradually sinks, turns its way in. It will always go peacefully. Don't worry about it. Don't be in a hurry. The moment you find the loop goes in and turns around, you will be able to. In case it doesn't, remove your loop, slip it all over again once, and you should be able to get it in easily. If it doesn't move smoothly, you got it in the wrong place. Take it out and just put it again, as you saw me doing this time. That's the important thing to remember. And then you can, of course, cut it into two little pieces with really no hassle and no difficulty. See it going past the horizontal line. Once you see that, then of course you can just cut it. As long as you're careful, you can manage comfortably. Please remember, before you remove the loop, to twist and turn it around. So this is a very simple method, which I think now every cataract surgeon should have lying with him to handle, because it makes life very simple, makes life very comfortable, irrespective of the density of the cataract. It makes no difference. And your eye is almost pristine the next day. So I think it's something which, I started using it only for fun. When I first saw it, I said, let's see how it works. And then I was quite impressed with the fact that it makes my life very simple. Now, a hard cataract makes no difference. You use the Milo and that's it. So I thought this is something which I should share with you.
Yeah. Thank you, sir. I think Milo is, I'm sure for many people, this is the first time they must be actually seeing a presentation on Milo. And so in this, sir, hundreds of cases that you have done. So apart, like in one case that we have seen where you had a very hard, like grade 5 brown cataract, where it got a bit stuck at the equator in the beginning, but it then rolled over. So apart from this, what are the other challenges that you have faced in these cases?
You see, one thing you have to remember, that the more dense cataracts, the lesser is the cortical buffering material which is there. Lesser is your margin of safety.
Yes.
So one of the methods which I have now devised essentially is, besides doing a little hydrodissection, is to inject a little bit of viscoelastic under.
Right.
That gives you the lubrication which enables the loop to swing around. But barring that, really nothing else. And of course, remember that the loop only works 5 times.
Okay.
It has been very, very interesting that they prevent you from doing any more.
They are masters.
You can utilize it for 5 cases. Remember, you have to wash it thoroughly every time.
Sir,
recommended as a single use.
Sir, for everybody's information, what is the approximate cost for this Milos?
It is 11,500.
11,500 rupees. So we have seen
5 cases.
5 cases. Yeah, not bad actually in that way. And you have seen that, I mean, of course, you are having magical hands, but for average comprehensive ophthalmologist, is it easy to master it, the Milo?
I don't think it should be difficult. The first time when I did it, I had this eyes guy standing at my side and saying, try kariye cheez, ya ho sake to try karna. Apparently, a lot of people had been given the Milo and they had quietly backed out of it. But I think the reason they backed out was very simple, because they were worried that everything was going to drop inside. I can frankly say that up to now, I haven't yet broken a posterior capsule. Though that doesn't mean it won't happen tomorrow, but aaj tak to nahi hua hai. So, I mean, as long as you can dissect it comfortably, that is it. So now the rule comes about that if you have a rock hard cataract, inject a little fluid, make sure that your lens rotates and then swing it in. Then life is easy. If you do it when you're a little lazy and you say, waise ho jayega, nahi hota hai.
Right. Super.
Time the extension of Capsulorhexis was there while putting Milo?
No, you don't need to. Milo goes in
No, no.
comfortably through a 4.5 millimeter capsular.
Yeah, but while putting Milo, was there any time that you accidentally
No.
cut
It
the-
doesn't extend. It doesn't. That is the interesting thing about the Milo. It doesn't do it. It is basically an atraumatic sort of a. I also thought the same thing of a capsule will tear. And I use Zeiss lenses. If you tear a capsule, your chances of putting a Zeiss lens is out through the window.
Actually, there is a surgeon from Dhule, Maharashtra, Dr. Anil Shah,
Yes.
and he has developed cataract snare long back, about 20 years back.
Yeah.
And he has used a stainless steel wire. Only difference is that you have to take that nucleus inside anterior chamber. Whereas in my loop, you are cutting a nucleus inside the bag. While he has to deliver nucleus in the anterior chamber, and then he cuts it with stainless steel.
Yeah. I had originally also developed the snare. I'd used a double snare, which makes you cut your lens into 3 parts, making it easy to remove. But with all of them, you see, the snare never became the size, became a duplicate in size of the capsule itself, of the bag itself. This particular thing opens in that shape, which is why I think it is so safe. I mean, the Zeiss themselves don't talk about it, but I mean, that is what.
The tensile strength remains same even on 5th case as it was in the first case.
After 5th case, it locks, it doesn't open. But till 5 cases, it works.
Equal or gradually reduces.
There's no difference. It goes in looking the same.
Right.
Keki sir, can I ask a question?
Sure.
So, do you further subdivide the nucleus, or you just make the first half?
You can cut it into 4 parts. You can cut it into 4 parts. You rotate it inside and then put your loop again.
Okay, so you are saying it works for 5 times. So that count is.
Do that means do mein use ho jata hai.
Yeah.
Okay.
Right. So
You see, the big advantage is once you cut it into 2 parts, that part, when you're removing the loop, one part gets lifted out, the part on your right hand side. So when you put your phaco inside, you are already onto the lifted part, which makes removing that little slice, as one would call it, a very simple procedure.
Great. Any other comments from any other faculty? Dr. Smith, Dr. Deepak, Dr. Arup sir, Samresh?
I would suggest one thing, you all go and try it.
Yes.
Besides the fact that it works, I mean, it adds a little more fun to life.
No, it will certainly reduce phaco times, so it will be better for the endothelium. It will be better for the post-operative.
Because you're not handling too much of it. Yeah. And the big advantage is the safety. Because very often, when you have a rock hard cataract breaking into little bits with no capsular material lying behind, there's always the risk of breaking a capsule. Here, that risk is almost totally removed.
Any of you have used the Jacob? Any of you have used the Jacob
manual SICS half phaco, I mean, when it's done.
Yeah. It is basically.
What about zonules, sir? Any chance of damaging zonules?
No, I've done it on even where the capsule bag is a little loose. No, it does not make a difference. Because you are not holding the zonule in any way. You're not holding the bag in any way. You're only holding the lens.
I think Dr. Sahu sir wanted to ask something.
Any of you have used the Jakobovich chopper?
The pre-chopper?
Jakobovich chopper.
Chopper, you mean?
No,
I will show you
that.
So instead of my loop, this chopper, how it is dividing the nucleus, you will see in my video.
Okay.
Absolutely, there is no need for a blind procedure going behind, and because with Keki's hand, it may look very magical, but for a new person, he may just damage the bag in a big way. So anyway, every surgery has its downside, but
it's a great idea
the master is doing it to look easier. So anyway, we will see that video.
Absolutely. Yeah.
Just one thing, excellent surgery, Keki sir, as always. But if there is an anterior capsular tear, would you go ahead with a MyLoop, and would you think that would
you
trigger it going into the
you need an intact bag.
Yes.
You need an intact bag.
CCC is a must.
Intact
Intact capsulorhexis is a must.
Yes.
Great.
And
Yes.
of appropriate size, I think. Capsulorhexis should not be
It's
very
a smaller
small.
one, then definitely it will.
5 millimeters is minimum, but that's what I tell. But I mean,
I think, Keki sir, I think it's also very good for Morgangian cataract, where, to chop the Morgangian cataract is difficult. You can put some OVD around it and you can just use this Milo to cut it into half.
Yes.
For those kind of cataract also, I think it should work very well. Yeah.
Yeah, I think it's very advantageous in that. The
Yes,
nucleus
yes.
will be moving around left, right, and center,
Yeah.
and they'll be like
It's easy to
really
do.
hard nuts. So put in a
Yes.
OVD and then pass it, and then
Pass it through and yeah.
True. Yes.
Hook it and then do it. Great,
Thank
great
you so much.
demonstration of surgery, Dr. Keki sir.
Thank you.
Thank you, sir. Yes, Dr. Peterson, next.
Yeah, so our next speaker is Dr. Deepak Megur, who is head of cataract and glaucoma department at Megur Eye Center, Bidar, Karnataka. We all know that he's a brilliant surgeon and he has his video YouTube channel with a lot of followers on those YouTube channel. He has received many awards and he has also received CS Reshmi overall best video award by All India Ophthalmological Society in 2020. So Dr. Deepak Megur, over to you.
Thank you for the opportunity, sir. Thank you, MOS, for this opportunity. So I'll be speaking something on very basic, like I'll be speaking on the few pearls on management of the posterior capsular tear. I think we all know that whenever we break a capsule, like we have certain goals, and the first two primary goals would be like, to prevent the rupture of the anterior hyaloid whenever we have PC tear. And if it is already ruptured, then prevent the enlargement of posterior capsular tear. And I'll be speaking on how to achieve this at every stage. So, we usually see that, we always put in a dispersive OVD first whenever there is a posterior capsular. The first thing which I would want to highlight here is to watch the bottle height. See, fluidics play a lot of important role, decreasing the bottle height, just getting down the bottle height before you start your vitrectomy ensures to blow open the posterior capsular tear. So sudden deepening of the antechamber, because whenever there's a posterior capsular tear, both the chambers have become one. There's a communication. So whenever we push in fluid, it's going to enlarge. And second thing always is also, if you're very careful, you can prevent the rupture of the anterior. So let us go through a few cases. This is a posterior polar cataract, and there was a posterior capsular tear. So I'm injecting dispersive OVD through the side port to ensure that the chamber is maintained always, and using very low bottle height and to match it with low vacuum and aspiration flow rate, very slowly and steadily, you can just remove the epinucleus in the cortex. And the shape of the underlying posterior capsular tear tells us that, the vitreous is still not prolapsed. So until all these stages, you can still go ahead and put in the lens into the bag. And also in a very controlled manner, you can also remove the OVD, but still keep the anterior hyaloid intact. So the message here is, if you can take care of the infusion pressure and don't suddenly deepen the chamber, you can prevent the rupture of the anterior hyaloid. Now, this is another case where the shape of the posterior capsular tear is some story. So we have got a PC tear and also the anterior hyaloid rupture, which can be seen. And the shape of the PC tear indicates that probably the vitreous is already out now. So with retrolamination, we can always delineate it quite easily now. And I'm trying to push in OVD at the opposite end. And you can see that it is clearly evident that the vitreous is already prolapsed out. And along with the pressurized chamber, along with the viscoelastic, the vitreous is trying to head towards the side port where it has got an access. Now, our goal is to minimize the extension of the posterior capsular tear during antivitrectomy and also during the posterior capsular, during your IOL implantation. So these are the stages where the PC tear can open. The first thing, obviously, we do is after the OVD, we all go in and stain the vitreous, try to identify it. And the first thing which I want to do here before entering my vitrectomy is lower down my bottle height. So you can see the bottle height is reduced to 28 centimeters, and I'm not even gone with the infusion now. The first thing which goes inside is the cutter, because the chamber is still maintained with the OVD now. So we don't want sudden deepening of the chamber that is going to blow out the posterior capsule and open it more still. So first initial vitrectomy is done to remove the vitreous which is around the wound there. And just as you can see that the chamber is fluttering a little bit, introduce the irrigation inside with a very low bottle height. It's at about 28 centimeters. And now the probe is held at the level of the posterior capsular tear. And then the vitreous which is around the posterior capsular tear is taken care of. The port is then turned anteriorly, then the vitreous which is there in front of it is taken care of. The important point is the positioning of the cutter. It has to be at the level or below the tear and with a minimum infusion. And once the vitrectomy is, when the vitreous is taken care of, the chamber starts to flutter a little bit. The time when you want to increase the bottle height. So it is a dynamic thing. You begin with a low bottle height, and as the vitreous is cleared off, the bottle height is gradually increased. So if you can maintain the fluidics of a very calm chamber inside, most often than not, you can also prevent enlargement of the PC tear. And of course, once the vitreous is taken care of, you're going to convert it into a and then you still have an opportunity to place the originally planned single piece lens into the bag. So these are the pictures which show the PC tear before doing the vitrectomy and after doing the vitrectomy. They're almost the same. So that was the goal which we started off, and we could achieve this by following certain basic principles. So even using a limbal route, we can minimize the extension of PC tear if we take care of fluidics. As has been taught to us by Dr. Vasavda, that posterior approach is beneficial in preventing the enlargement of the posterior capsular tear. That's a very well-known fact. And but even if you're careful, using the anterior limbal route, we achieve the same goal. Again, we have a PC tear. I'm trying to stay in the vitreous, and again, the bottle height is kept at 30 centimeters when we go. So this is one trick which really helps us to minimize the extension of the posterior capsular tear. Gradually, you start off with very low, 28, 30 centimeters, and as the vitreous is evacuated, then you raise the bottle height. And once the vitreous is taken care of, that's the time you take care of the remaining cortex which is there, and the bag is filled with cohesive OVD, and gently the foldable lens can be manipulated into the bag. And even in fact, you can, with a very low bottle height, you can lift up the lens and remove all the OVD as well. Of course, in this case, the vitrectomy is already done, so I'm going to use the cutter itself. But the most important thing is, just watch out for the fluidics. If you can go slow and go low with your infusion, PC tears enlargement can be prevented. And at least the basic principle is, you have to lower the bottle height. At the same time, don't compromise on the antechamber equilibrium. I think if you can follow these two principles, we can minimize the extension of posterior capsular tear in most situations. Thank you for attention.
Videos. Superb.
Thank you, Dr. Deepak. Yeah, I think it was, of course, it is like
Amazing
masterclass of the PC rent and amazing demonstration. I think amazing videos, right? Absolutely. So, as we discussed, like Dr. Vasada sir will always advocate the posterior route. And here, one good tip that you have discussed is where should be the tip. Because I think a lot of surgeons, what they do is they keep the tip of the vitrectomy at the pupillary area or even above some time and keep dragging the vitreous out. So I think this tip of first kind of like, let's say, isolating the posterior vitreous from the anterior by actually doing the posterior cut first and then going to the anterior was really nice. But do you really like choose some time when to go posterior route versus when to go anterior route? Is there a way, or you always go through the limbal route right now?
If the posterior capsular tear is really big, like, very large, and that's the only time where I would like to go ahead and do the posterior. But nowadays, which I have realized is most often than not, I'm able to salvage the extension of the posterior capsular tear even through the limbal route itself, as long as I'm able to control the fluidics well. So if we have a tear which is very ragged, and the slightest manipulation, it has a risk of running to the periphery. Those are the only few cases where I would go through the pass plan approach. Otherwise, in most situations, I'm able to manage with these situations, these things.
I'd like to take probably a comment from Samresh about like their experience of posterior route.
I think the first thing that I would appreciate about the talk that Begur sir gave is the fact that you have to understand your machine. I mean, because to get your cut rate, your flow rate, he reduced his bottle height because he wanted no turbulence in the anterior chamber, highest possible cut rate, enough vacuum to eat. And that I think is something which is most paramount important, more important than going limbal versus pass planar. Because if you don't know your parameters and you increase your bottle height, it will split up in no second. And like sir brought about, if you know your technique through limbal, sometimes you can get away. So I tend to use a combination of pars planar versus limbal. My preferred technique is to go pars planar first, remove vitreous in the area of the posterior rupture and a little beyond that to create a scaffold which is symmetrical. And if there is any anterior vitreous which is left behind, or maybe it's guillotined and it's hanging in the anterior chamber, I go limbal and clean off that left alone vitreous. But again, it's not easy to do pars planar in topical surgeries. So it takes a little bit of experience and a little bit of good anesthesia, good anesthetist in your back, to inject something to calm the patient down when you're putting that trocar or an MVR through a pars planar route. But I think most important message, I think one would be, like I said before, if you don't know your machine, even before you had your first PCR, it's very important to know your parameters and know what works to bring down the turbulence in your anterior chamber. And with that, mostly, I would say a combination of both would work brilliantly.
Yeah, so basically it is isolating your posterior vitreous from the anterior and then dealing with the anterior.
The first mistake most of the people do is they don't reduce the bottle height.
Yeah.
Okay, that's the single most. See, whenever there's a PC tear, your chamber, all chamber has become one. The anterior chamber and the vitreous chamber, there's a direct communication. So whenever you put in the fluid, it directly goes inside. It gush. See, when you're doing a cortex aspiration, the bottle height is typically kept at 90 centimeters. You don't have to have any high-end machine. Okay, the bottle height is typically kept at 90 centimeters. You already pushed in OVD, the chamber is already flat, and then you are going in with the 90 centimeters to do the vitrectomy. The moment it starts the infusion starts, it just had nowhere it has to go down. So it just enlarges and it enlarges. So if you can control that part of it, then the second would be positioning your cutter. The potter has to be, as has been, you achieve the same principle as Dr. Basavada taught us that, go from behind. You can go behind even through your limbal route as well. But before that, you shouldn't rupture or open the PC tear. That is what is the idea here. So 2 points, that's all.
I think one more point that sir brought about, which is again very important to emphasize, is please do when you remove your instruments, do a viscoelastic exchange, preferably a dispersive viscoelastic, because the moment chamber collapses, that big vitreous is going to come up anteriorly and it's going to mess up the system there.
Yeah, usually we have always been taught to maintain a positive pressure, but this is one situation where I want to highlight that excessive pressure can also blow out the capsule. So we have always been taught to put in more OVD, and at the same time you're going with a very long, higher bottle height, 90 centimeters. Then it's going to force you through it and then open it up. So that's the principle. And even AC maintainer, using an AC maintainer is a good idea, but again, AC maintainer, you begin with a low bottle height. Again, if you get an AC maintainer top again, it's not going to do the justice there.
One point I'd like to offer. Thanks, Deepak. Wonderful videos as usual. It's all as if your PC is almost planned, So, anyway, the thing is, which side should the cutter be facing? That's, I think, very important. You see, anterior segment surgeons, I have the benefit of traversing both sides. So anterior segment surgeons would love to see that cutter port, you see, and see that vitreous going in and things, stuff like that. That's actually not necessary and could be counterproductive. If you have in that anxiety, not many people have the calm and composure of Deepak Megur when you are faced with a PC rent. So if you have the cutter port facing anteriorly and you are a little careless about your movements, you could probably extend that PC rent by chewing up some part of the posterior capsule. So it is always better to keep your port either face down or sideways. It does a very good vitrectomy. It pulls the vitreous back behind the posterior capsule plane, and actually, unless you are very comfortable with a pars planar approach, that's fine. But if you're not, you could use a limbal approach, keep your face down or sideways. Do not actually turn it facing yourself. That way you could actually damage the posterior capsule.
Yeah, great tips. Thank you, Dr. Spencer. Absolutely. So I think we had very good discussion. Thank you so much, Dr. Deepak. I think it was amazing video demonstration and great pulse shared by everybody. So I think now we will move on to our next expert faculty, who is none other than Dr. Arup Chakrabarti, sir. Of course, again, Dr. Arup, sir, doesn't need any introduction. Even in all India level as well as at global level, he has been such a prolific teacher. Even in American Academy, sir's courses have been full course year after year. He is currently, of course, he's a very passionate teacher. He has been the editor proceeding of AIOS since 2017. He has been the president of the Kerala Society of Ophthalmic Surgeons in 2021-22. He has won the Senior Achievement Award and the Achievement Award from the AAO and the APAO. He has been bestowed with the FAICU in cataract surgery, and he has won more than 10 named Oration Awards. And most importantly, he is the member of a very prestigious IIIC club, which is very exclusive club for only the top innovators in cataract surgery in the world. Over to you, Dr. Arup, sir.
Is my screen visible?
Yes.
And I'm audible too.
Yes.
I would like to thank Maharashtra Ophthalmic Society for organizing this massive event, and Dr. Deepak and his colleagues for the very kind introduction. Well, there are a lot of challenging phaco situations that all cataract surgeons have to take up, and one such case is a post-vitrectomy cataract. I have been doing this kind of cataract for about last 3 decades. My wife is a VR surgeon, so I get a lot of patients for cataract surgery who had undergone all kinds of simple vitrectomy, complex vitrectomies, advanced, and so on and so forth. What I would like to tell you is, for a routine vitrectomy cataract, the cataract's phaco procedure is not much different from that of a routine. When you see the video, it appears as if a routine surgery is going on. Now, the problem or challenges start when you have to deal with a patient who has undergone multiple sittings of vitrectomy. There have been, silicone oil in the silicone oil tamponade that has been used in the posterior segment. So I have a series of videos, but I'll just confine myself to, one video today, and let us see that. Yeah. So this is basically a patient who had emulsified silicone oil bubbles in the anterior chamber, and many of these patients.
Video is not seen.
We can't see your video.
You can't see the video?
Oh, no, video is not
Stop
seen.
sharing that slide and then reshare your video, please. You open your video and then start sharing.
Is it visible now?
Yeah, now, but it's not playing. We can see.
No, it is paused. It is paused. Yeah. So, this is basically a patient who had been delaying his cataract surgery for a long time, and so he came to us, with emulsified silicone oil filling the anterior chamber, and let us see how the surgery goes. Yeah. So these cases tend to be very soft generally. So you should use a very sharp set of instruments, MVR blade, or whatever 15-degree paracentesis. In this particular case, the keratome won't enter the anterior chamber. So I had to hydrate the anterior chamber, inflate the anterior chamber to build up the pressure, and using the same keratome entered the anterior chamber. It is always a good idea to stain the anterior capsule with trypan blue in these kind of situations. And also remember, the endothelium tends to be compromised because silicone oil has been in the AC for a long period of time. So it is imperative that we use a soft shell technique. And you, as I mentioned just now, you have to stain the anterior capsule because there will be fibrotic plaques. Some of them may be unrecognized before surgery, or you may land up with zonular problems, or if there may be rhexis run away to the periphery. So in that situation, the better visibility definitely will make life much easier for you. So I've used a soft shell technique where visco-20, and then after that, Hilon goes into the eye. So that is important. Rhexis has to be done very carefully because there may be fibrotic plaques. In this particular case, we don't see that. Sometimes there may be zonular issues. So when you make the first puncture, you realize that the zonules are not very stable. And in this particular case, the Rhexis went pretty well. I would not make a Rhexis which is more than 5 millimeters in size because the postoperative centration and continued stability of the intraocular lens is greatly dependent upon the 1 millimeter overlap that you have on the optic margin. Hydrodissection again has to be done extremely carefully because some of these cases may have a deficiency in the posterior capsule, particularly those cases where the cataract progresses very fast, very rapidly, immediately after vitrectomy. So if it has happened in our center, which is very rare, then I would not perform cortical cleaving hydrodissection. Otherwise, I perform a cortical cleaving hydrodissection very gently, making sure that there is no posterior capsular blowout. And then this is a special trick that you have to employ because if you come in position 2 and irrigation starts, because of the pressure gradient, you may have a very deep anterior chamber, because lens iris diaphragm retropulsion syndrome. So this is a simple trick to avoid that. Take your Sinskey hook and sometimes you may even use your phaco needle. You elevate the iris from the anterior lens capsule so that there is rapid equalization of pressure between the anterior chamber and the posterior chamber, and there is no deepening of anterior chamber that happens. Otherwise, the visibility may be very compromised, particularly when you have, a cochlear cord incision which is very long, dissected very long into the cornea. Then I decided to debulk the nucleus a little bit and going for a chopping technique, but it all depends upon the surgeon. Employ a technique with which you are very comfortable and what works best in your hands in terms of capsulozonular stress is concerned. So you will soon find out by trial and error what are the right phaco parameter setting that will give you a good chopping. And it is enough to see the chop line travel up to the center. It is not necessary to use brute force and divide the nucleus into 2 halves in one sitting itself. These are deep anterior chambers, so I would not really go for some 6 or 8 pieces of nucleus because I have a lot of space in the capsule, the iris plane to play around with, and the nucleus has been removed. You must remember that there is always a vitreous the silicon oil upthrust in these cases. You can see silicon oil shimmering through the posterior capsule. There's a capsule spidering sign that happens, and there is a lot of silicon oil droplets which are stuck not to the posterior capsule, the anterior surface, but the posterior surface. So they're fortunately not in the axial area, in the paraxial area. So I don't really think about doing a posterior Rhexis in this kind of situation. So here, my plan is also to implant an intraocular lens and remove the silicon oil. The posterior segment surgeon is standing nearby so that she will perform the silicon oil removal if necessary. And sometimes we postpone the silicon oil removal. Sometimes we inject some more silicon oil into the posterior segment. So please be careful at this stage that you have an intact posterior capsule. This is a hydrophilic acrylic lens that is going into the capsular bag. And I definitely am not very much in favor of using a hydrophilic acrylic lens in these bags. Studies have shown, and in the past also I've noticed that there is a much higher incidence of IOL tilt and decentration in cataract surgery in post-vitrectomy situations, particularly when there is silicon oil. So it is always better to use a single piece hydrophobic acrylic lens. It is important to have the Capsulorhexis overlap, as I mentioned earlier. Then try to polish the anterior capsule as much as possible so that reduce the quantum of capsular fibrosis that sometimes happens very rapidly in these situations. And I would not hesitate to use a capsular tension ring more often in these situations. And if your swept source based OCT determines whether there's a lens tilt or not, post-operatively, these patients will continue to have crystalline lens tilt. The lens, the pseudophakic situation will have the lens slightly tilted. So you may not opt for an aspheric lens in this case because we know aspheric lenses do not tolerate much of decentration or much of IOL tilt. So my job is over. Since the eye is pretty soft, so I always close this incision with one 10 nylon suture. Then silicone oil removal is going on. and the posterior segment surgeon decides that silicone oil is not really necessary, and subsequently the incision is closed. And another issue that you need to be worried about in these situations is, the intraocular lens power issue. In this case, it's not much of a problem because we have removed the silicone oil. In certain situations where the patient's condition is systematically not very good, patient may not be living for more than a couple of months. We would use the maybe 6 diopters more than what my biometer tells me about the particular IL power to reach the target refraction. So this is the end of the case, and this patient has done pretty well. So this is what I wanted to discuss with you in my presentation.
Yeah, great demonstration, sir. As always, it is to learn from you, especially as you said, because of ma'am, you have a opportunity to perform a lot of posterior vitrectomy cataract surgeries. So basically, have you encountered anywhere where the PC was already open because of the posterior vitrectomy done in the past, and the nucleus was not very stable? How did you tackle those situations?
I have had cases done in my center, not so much, but referred from elsewhere, where after vitrectomy, the patient came back with an intumescent cataract. So the surgery had to be done immediately. And many of these cases I have done in SICS, I have not done a phaco. And of course, when the intravitreal injections were becoming very popular, and the general ophthalmologists were doing it, we're giving intravitreal injections without being aware of the technique. We did a lot of cases. This happened about 5 or 6 years back. I did a lot of cases where the posterior capsule is already scraped and it is already open. So yeah, so sometimes, if it is not a soft cataract, it's a hard cataract, it's better to, err on the side of a small incision cataract surgery than continue with phacoemulsification.
Yeah, I think 2 good clues, as you said, was if it is a cataract that develops very soon after the vitrectomy or after anti-VEGF injection, and the second one is that if it's an intumescent cataract. So I think those 2 may be a clue just to understand that the PC might be open in those situations. Be careful. Any other pearls to be shared by any other experts? Yeah.
I think
any tip for SICS surgeons when you said that you err on SICS, especially post-vitrectomized eyes, when the scleral rigidity is a big challenge? Any tips from your side for doing SICS in such cases?
As to how to make the tunnel, or how to...
Yes, how to make the tunnel. Any tips for tunnel?
Some of these patients, yes, they are myopic patients. They have a very thin sclera, and one has to be very careful. But anyway, I also have been doing SICS for the last 30 years. So one just has to be very, very careful. Cortical cleaving hydrodissection is to be avoided in these cases to get the nucleus into the anterior chamber. So that is it. So try to avoid penetrating through and through the sclera into the choroid while making the tunnel incision, and then you don't do cortical cleaving hydrodissection.
Sometimes you find
and in that case, if you're doing an SICS, you can make a little larger rexis because you're going to insert a rigid lens anyway. Try to go for a 6.5 or 7 millimeter optic lens, so that if you have a larger rexis, in that case it becomes easier for you to prolapse the nucleus into the anterior chamber. Yes, Amresh, sorry to interrupt you.
No, absolutely not. So sometimes in patients who've had vitrectomy and silicone oil and have had oil removal and come up with a cataract where there's a plaque on the posterior part of the posterior capsule. So I tend to leave them if they're, in the axis where I can do a YAG later. But what would be your take on it? Would you implant a lens and remove them with a vitrector, or how would you?
Sometimes, these plaques may look really aggressive on the table, but if you see them in the postoperative period, there are some cleared windows through which the patients don't have much issues. Many of them may not be seeing 6.6 or 6.9, but sometimes it is a very thick plaque in the center, and though it is not going to give access to any light whatsoever. I do a central posterior axis, and if silicone oil tamponade still is required, then I'll obtain a posterior capture of the optic through the posterior axis, so that this prevents the silicone oil from behind. Otherwise, you will have silicone oil post-operatively when everything was fine coming into the anterior chamber. So that can be avoided by doing a posterior axis in situations where there is a thick plaque which is integrated with the posterior capsule that you can't tease it out from the posterior capsule.
Perfect. I think quick comment from Dr. Gupta, sir. He wanted to say something.
And another, as you said, that perhaps doing manual SICS can be better. And there, I think even putting in a suture, I think, is very needed, because many a times their globe integrity is not that good. The skeletal rigidity is not that good. So perhaps
Even for the clear cornea incision, I would put a suture, because his eyes will be pretty soft. So, if you want to really have a normal pressure, you have to do so much of stromal hydration that, cosmetically doesn't look nice. So I would just rather put a suture and then, do a little bit of suture, stromal hydration, even if it is a 2.4 clear corneal incision.
Great. All right. Thank you, sir.
That's a very good tip.
Great pearls shared, Dr. Arup, sir. Thank you for your time. I think over to you, Dr. Bide, sir. Yeah.
Our next speaker, Dr. Harshul Ta. He is member of ARC Central Zone. He's also executive committee member of IIRSI, and he's a past chairman scientific committee of Rajasthan Ophthalmologists Association. Dr. Harshul, over to you, please.
Yeah, thank you so much at the outset to entire Maharashtra Ophthalmic Society, Dr. Vardhaman, Dr. Anaga, Dr. Santosh, and all the members. So I'll be sharing few videos about Capsulorhexis in some of the difficult situation and how to salvage Capsulorhexis. Can you see my screen?
Yes, yes, yes.
Let me pull out the.
It was seen in the old folder also.
Yes,
it was seen. Topple MOS. This one, yeah.
Yes. Yeah.
Right.
Okay, so we all know that to have an intact Capsulorhexis of good size and shape is very important for modern phacoemulsification. So let's have a look at this Capsulorhexis, which is going smooth so far. But as I reach this area, we can see the rhexis started to going outward. So always look at the direction of the rhexis where it's going. The moment you see that its rhexis is going outwards, you need to stop there. Go ahead and put OVD in front of the leading edge. So I go ahead, stop there, put OVD, flatten this flap, and now everybody should learn this, how to pull this inside by getting your forceps in the center. So your forceps has to come in the center. It has to be a centripetal force. So if you see clearly, I'm pulling the forceps inside, and in that process, the rhexis is coming right back on the track. So this is a very important maneuver to salvage the Capsulorhexis edge, which is going outwards. Let's have a look at this again. So this comes right in the track. Let's have a look at another case. In this, the pupil was moderately dilated. Again, Capsulorhexis is started to go beneath the pupil and outwards. And I can't see the leading edge now. So whenever we have a situation like this, so have a look at this, rhexis is going outwards, slipping down. So whenever we have situation like this, we should never do anything blindly. So what I decide here is to go and put an iris hook there in front of the leading edge so that I can visualize where the leading edge of the Capsulorhexis is. So I make a side port here, and after making a side port, I go ahead and put an iris hook, getting the hook from the different directions so that I don't damage the leading edge. Hook this to the side port, and then I can visualize the leading edge. And again, using the same technique, you can see the leading edge. So direction of the pull has to be centripetal. Look at the direction in which the rhexis forceps is going. And you can see the leading edge is coming right back on the track. So this maneuver is very important. Everybody needs to learn this, especially the younger surgeons. So So there's another case where you can see the edge is going outward. The same thing, I'm holding it from near this and pulling it in the center, and it gets the rhexis right back on the track. So this was about how to retrieve the rhexis, which is trying to go outwards. We all know that it's really difficult to make capsulorhexis in intumescent cataract because there is high intracapsular pressure. So the technique which I've been advocating is a sequential two-stage rhexis. Put an high molecular weight OVD in the central area. We can easily make a capsulorhexis with micro forceps. And once you make this, use a 27 gauge cannula and look at these fluid-filled pockets there, which are all around. So go from main port and aspirate this liquefied cortical matter. I think everybody can appreciate the amount of liquefied matter which is going in. It's important that we go not only from main port, but after debulking from this area, go from side ports as well, because we need to debulk the entire capsular bag. Again, liquefied cortical matter is coming in the cannula. Again, I'm putting high molecular weight OVD here, going from another side port. And once you have debulked the capsular bag like this, you'll realize that it's very easy to create capsulorhexis. Go ahead with micro scissors, give a tangential cut there, and use a micro forceps again to enlarge the rhexis to appropriate size in the first go. Have a look at in one more case. Again, same thing, making a small rhexis, going ahead, putting OVD in front of it, making a very small rhexis, debulking it from all around, and creating capsulorhexis of perfect size. We may encounter capsular anti-capsule like this, which is fibrotic. So it's really difficult to use a freehand technique to make capsulorhexis through fibrotic areas. So always remember that whenever we reach the fibrotic area, we need to cut through them with the micro scissors. So I just lift the flap from the clear area here. You can also use vitrectomy cutter, but scissors will also do the same work. So I'm cutting through this fibrotic area, but you need to use bimanual technique to hold the flap, capsule flap with one hand and cut with the other hand. So here, there's a clear area, so I'm just trying to take it through and going through the side port. And whenever you reach the fibrotic area, you need to cut with micro scissors and use forceps wherever you have clear area. So you can make a capsulorhexis this way. And this fibrotic areas where you're cutting through, they are not weak areas. They are strong enough to withhold the pressures of the phaco, as here, finish the phaco. And one thing about the secondary enlargement, we should always try to enlarge the capsulorhexis to appropriate size once you put the IOL. Here I've just finished the IOL implantation and just putting the hydro cannula itself. I've given a cut there and going through the side port, I'm enlarging the rhexis to appropriate size. Again, there's a multifocal lens, so rhexis is small in this area. So go ahead, we'll give a tangential cut with micro scissors and enlarge the rhexis, because we don't want much of the capsular overlap. We just want a 0.5 millimeter overlap at the IOL optics so that we have good effective lens position of these IOLs. So you should always try to secondarily enlarge capsulorhexis to appropriate size. Again, rhexis is small here, give a cut and enlarge it to appropriate size. Okay, so what about the pediatric cataract? Whenever you have cataract like this zonular cataract, which is almost 5 millimeter in size, you should always stain it because visibility becomes very poor even in retroillumination. So I've stained the anterior capsule, and you should always use micro forceps because the capsules are very, very elastic in these pediatric cataract. And again, after doing phaco and putting, there's a toric IOL which goes in And once the toricile goes, the rhexis is smaller in size. So put OVD in front of it, give it cut and enlarge it to the appropriate size and suture the wounds. This is a lens-induced glaucoma. And again, same technique, make a mini rhexis and then enlarge the rhexis to appropriate size. And what about the cataract, which are not intumescent, but they are a bit bulky? You can use a spiraling of rhexis. So if you realize that there is not much of intracapsular pressure, you can start with a smaller rhexis and then you can spiral it out to create the rhexis of perfect size. Again, fibrotic subluxated cataract and using bimanual technique to cut through the fibrotic areas. So I think with this, I'll end my presentation here and we can take any questions which are there. Because
Excellent.
Very good. I think, Dr. Harshul, it was
Thank you so
amazing, wide
Excellent, sir.
variety of difficult capsulorhexis. I think before we go to Dr. Subhen sir's question, I had a very quick question for you. Is basically what about those incidences where you can't really retrieve it to go inside? Like you have shown wonderfully that maneuver where you are actually able to retrieve it back. But there are going to be circumstances, let's say that it has gone across the zonules and you can't retrieve it back. So how do you deal with it? When do you know where to stop?
so the thing is that, as I showed in that case, you should always keep an eye on the leading edge. So nowadays, most of the time, we just able to retrieve them back. But if there is a torn rhexis beyond, it's gone till the equator, then of course it's like a phaco in a torn rhexis. So I start from the other side and try to convert whatever is there into a complete opening, and in one area which is weak area there's there. So then we need to decide that how to go about it. So I always prefer to do a closed chamber technique. So I do very limited hydro, always maintain closed chamber so that we don't get the wraparound in the posterior capsule. So if we can achieve that, I think we can very well do phaco in torn rhexis also. I have a lot of videos to show. I thought Dr. Deepak was showing in torn rhexis, so I didn't show those videos.
Right.
So
I think Dr. Subhen sir wanted to say something.
Yeah, thanks, Harshul, for bringing up those wonderful topics. As an excellent surgeon, something about the extension of the capsulorhexis. I would like to be very, very clear over here. What Harshul showed was an excellent use of a tearing force to retrieve the capsulorhexis. The Brian Little technique is a use of the shearing force. I think it's very, very important to differentiate between those two. A surgeon needs to use them appropriately at every stage of surgery. Now, let's come to the basics as to why we are using that viscoelastic at the site of the leading edge of the tear. If you inject, most of us instinctively, as soon as we see the capsulorhexis running out, would like to inject viscoelastic into the center of the chamber. And what happens is if you have soft cortex, that pushes it to the periphery like a donut, and that capsulorhexis is going to extend to the periphery further. So that is counterproductive. So you go and inject a high molecular weight in the viscoelastic or whatever you have at the site of the capsulorhexis extension. So you flatten that area. Second is the Brian Little technique, which we have tried and tested, is basically you bring the flap back. It was everted. You now bring it and place it flat. And let's say this is your capsulorhexis tear. Okay. Now just taken 2 pieces of paper. This is a shearing force. This is a shearing force. This is tearing. I think this must be very clear. So the shearing force is what is the unit you use to control that capsulorhexis from going outwards and coming back. So you put that flap back, hold the capsulorhexis with the forceps and drag the capsulorhexis back to where you were coming actually from. So if you are coming from right to left, you go from left to right and drag that capsulorhexis in the opposite direction. And that's when you use that shearing force appropriately to turn that capsulorhexis inwards. That is, I think, that Bryan-Little's technique should be very, very clear to every surgeon who's starting, because that is invaluable. Now, you did ask something, Vardhaman, about the capsulorhexis extending. And actually, Harshul, trust me, I would not hesitate to use the Bryan-Little technique, even if my capsulorhexis is under the iris and I can't see it, because it works almost every time. It works every time, unless your capsulorhexis has extended to the zonules. See, once it's extended to the zonules, then what happens is the forces get totally messy, because the zonular attachments are now playing very different games. So you have a traction and a counter traction in very different directions. So if you can see the zonules sometimes, and you're brave enough, you can actually segment the zonules in that area and then retrieve the capsulorhexis. That would be a good idea. In fact, I think Saurabh Patwardhan has got a video online, which you could see. Those are, of course, anteriorly placed zonules. Sometimes the zonules are very much anterior and centrally placed, and you could see that. So that is the idea. You must use a shearing force. So put the flap back where you came from and drag the capsulorhexis to where you came from. Not ahead. You're not going ahead. You're going backwards, actually. You pull it back, and that's when you get the Bryan-Little's technique, and it works wonderfully.
In fact, we had 2 award-winning videos in last AIOC, one by Dr. Kumar Doctor and another one by Dr. Saurabh Patwardhan. And capsulorhexis in weak zonules. And since Dr. Kumar is there, he can comment on that. And maybe Dr. Harshul, you can also comment on tips while doing capsulorhexis in weak zonules.
So I think it depends on the severity of the weakness. So if zonules where severe laxity is there, so you can always hold with the other forceps also while you are creating this, because counter traction, you need counter traction to to carry on the capsulorhexis. Or you can, or what you can do is you can also put iris hooks to give counter traction, whenever you are doing capsulorhexis. So these are the techniques which I routinely use to give counter traction.
Capsular hooks can be used. Yes, that's right.
Dr. Kumar is there?
Yeah.
I don't think he's there.
Kumar has left. Okay. Kumar has left.
Great. So thank you so much, Dr. Harshul. It was really amazing, a wide variety of difficult situation for capsulorhexis. We learned a lot.
Just one comment.
Excellent,
yes. Excellent surgeries, Dr. Harshul. Regarding this counter traction, Dr. Chi Soon Paik had shown a video where with another person she actually holds the edge
That's
of
what
the
I was saying.
capsular flap,
Yeah.
and then she completes it. So
The
hook may or may not hold it, but she holds it with the forceps.
Anaga, Dr. Chi Soon Paik's surgical skill are something which we should actually be, using as a standard, because her surgical skills are absolutely amazing. So I think what we do is, most of us in loose zonules, what we like to do is have, like Harshul said, use a capsular hook. As soon as you've made the nick, and use a capsular hook and give a counter traction, and then we go ahead and complete the capsulorhexis. Because to have 2 hands working simultaneously, only some surgeons like Soon Paik can do it. She's amazing. She's amazing.
Quick comment. In fact, MOS had a webinar on cataract, and Chi Soon Paik was one of the faculty. And in that webinar, we asked her that how do you do it? How do you practice? Then she said that while doing routine capsulorhexis, you make use of 2 forceps and hold it and try it. Then only you will master it. That's what, in fact, Vardhaman was also there.
Dr. Bide, don't get carried away by what she's such a humble, modest person. Over breakfast, she'll tell you that the most complicated surgeries could be done by you. She'll convince you, and you can come back home and try it. It'll be a mess. She's a very, very skilled surgeon.
True. Perfect. Yeah. All right. So I think we will, because of the lack of time, we'll now move over. Has been having amazing discussions, great pearls. Thank you again, Dr. Harshul. And
thank you so much,
Subhen sir, for all your pearls. Fantastic videos. So now we have coming Dr. Samaresh Srivastav. Samaresh has been of course, a very dear friend, and we have been together for more than 15 years now. We were batchmates in Shanganitralaya while pursuing our DNB. Then he went on to do his FICO fellowship with Dr. Vasavda sir, did his refractive fellowship at Narayan Netralaya. He is, I think, amazing when it comes to his videos and teaching and out of the box thinking. He has won a lot of very prestigious best video awards at international conferences, including ESCRS, ASCRS, APACRS, and most importantly, the grand prize as well. And now we are looking forward to hear from Dr. Samresh about this POPs technique, which they have published in IGO in 2020. Over to you.
Thanks a lot, Vardhaman. Am I audible?
Yes.
So thanks, Vardhaman, and for the invite, and thanks to Maharashtra Ophthalmic Society. It's good to see so many familiar faces, and a lot of them my teachers also in this faculty. So I'm going to discuss in very brief, in the interest of time, a technique that was devised in our clinic predominantly by Dr. Viraj, which helps us in removing cortical matters. Although it may sound as a very simple technique, sometimes when you get stuck, and especially during your earlier formative years, bimanual IA or coaxial IA is one of those places where you cause the maximum PCRs and zonular loss simply because you don't know the fluidics of it. So like Vardhaman said, this got published in 2020 in IGO, and we were glad that it got through in the first attempt. So POPs is pretty simple. The POPs stands, all these prelims stands for the aspiration port in a bimanual IA, also in a coaxial IA, but predominantly on the aspiration port. P is where you position your aspiration. O is for occlusion. P is for posterior displacement, and I'll just show you why. And S is for swiping sideways before you remove the cortex, and I'll just elaborate it with the videos and animations for the same. So P, like I said, is for positioning, and positioning is extremely important. When you position your phaco probe, and I wanted to look at the animation down here, it's very important to go beyond the capsulorhexis margin in the area of the cortical chunk, not to hold right at the capsulorhexis margin, but a little beyond that is there where you want to occlude and position your, there is where you want to position your bimanual or coaxial probe, because that is where the more cortical material is to be able to grasp and cause an occlusion. And what you need is an occlusion, because only when you have an occlusion, a full occlusion of a phaco tip, of an aspiration tip, is when you'll be able to strip off these fibers completely. So notice how once it's there, occlusion is something which, as most of the cataract surgeons would know, you will hear by an audio input. It's important to keep your foot pedal in such a control that the moment you start hearing the audio feedback of your occlusion, like a ting ting or any other sound that your machine makes, do not give any more vacuum and don't start aspirating at that point in time, and let the occlusion hold and let the sound be there, because now you have a firm grip on this cortical matter. And it's important to do it this way, because the moment you have a firm grip, keep the vacuum at that level. Now notice over here, I'll just pause it for a second to show you that my vacuum is at 100, and that's where there is an occlusion and there's an audio feedback for me that's showing that there's an occlusion, is where you want to detach this whole cortical matter posteriorly down towards the posterior capsule. And notice in the animation at the bottom left how we are pulling it down so that we are able to detach the lens epithelial cells and the cortical matter at the equatorial region, which we cannot see. If we drag these cortical fibers anteriorly or centrally just straight up, what we are going to do is basically fracture the anterior fragments from the equatorial fragments, and a part of these equatorial lens cortical fragments may stay back and may never be removed and may be seen as fine fibrils at the end of the surgery. But if you cause a posterior detachment using the suction energy and the vacuum that you've occluded with, chances are that you will cause a complete cleavage of these lens epithelial cells. And once you've done this posterior detachment, swiping sideways, because if you notice over here, swiping sideways causes complete removal, not only from the anterior and the equatorial, but also from the posterior area of the cortex, leaving behind absolutely no cortex. And after you've done this good swiping movement is when you want to drag it centrally and cause an aspiration and put your foot position down. And finally, like I said, when it's down to the center, when you brought it to the center, that is when you press your foot position, get to your max vacuum, use a good flow rate so that the entire material causes complete cleaning of the capsular bag, like you see over here. But aspiration is always in the center of the bag, because according to the anatomy, the peripheries are shallow and you can cause a posterior capsule split if you do catch the capsule in the periphery. So I'll just show you the whole thing in action. So this is POPs, position, occlude. Now you know re-occluding. Then there is posterior detachment of pulling it, side by side swiping. And finally, when you come into the center is when you press your foot position, foot pedal, and you cause an aspiration. So occlusion, sideways swiping, and aspiration. This not only works for regular cataracts, but works brilliantly in cataracts like pediatric cataracts and over here in posterior polar cataracts, because you don't want to start eating these things in the periphery. When you occlude, posterior detach and start aspirating, you also create space for fluid to go behind and cause a cleavage of this posterior pole with a slow controlled manner. And like I said, it's very important to keep your irrigation as a second instrument ready at hand to inflate the capsular bag. Also your parameters, like I said, central vacuum. Vacuum is only to be pressed down when you're right in the center of the capsular bag. So this is just a small animation to end this, that if you just do a pull when you occlude, these are, if you notice, these white small things are lens epithelial cells. If you pull them centrally, sometimes these lens epithelial cells may not come out completely and may cause a fracture, leaving behind these things which are hidden in the fornices. And it is these lens epithelial cells that cause PCO formation, early PCO formation, and anterior capsule fibrosis as well. On the other hand, if you do a posterior detachment and you pull these lens fibers using occlusion posteriorly towards the equator and move it sideways, you're going to cause most often complete removal of these lens epithelial cells, and your chances of early PCO formation will be negligible to none, simply because your technique would be a little better than the normal technique. Thank you.
Very nice.
Yeah, wonderful, Samresh. I think it was a great demonstration of, I think, the ideal way of doing cortical aspiration. I think Dr. Bidey sir wanted to add his comment. Yes, sir.
It is similar to cortical stripping, which is taught to us at the beginning of phaco.
Yes, it's
It's
basically
just the same as
maneuver,
cortical stripping. Yeah.
except that we are going posteriorly in this just to cause lens epithelial.
Exactly. Yeah, that's the tip. You go posteriorly also.
So, Samresh, sometimes we see that out of doing the best form of cortical aspiration, sometimes those are small twigs of posterior fibers that you see on the PC. So what is your best step to get rid of them? Like, how do you deal with them?
So for me, honestly speaking, it depends on two things. One, what lens I'm implanting. Okay. And second, how much of time I have to give an honest attempt to remove those things. If they are central, I give a polish. And if it's a premium lens, like a extended range lens or a multifocal, I will give, a clean up of that area using very low vacuum, 5 vacuum and 5 flow rate, and a low bottle height, because I want my posterior capsule to come up so I can polish it. But if it doesn't come up in one go, I just don't bother, because I would not risk, rupturing the posterior capsule. I would just let my ego on the bay, put the lens, and if it bothers me later, I'll just probably do a YAG, maybe 1 month down the line.
And what about like post CTR? Many times we find that, like, let's say that you have actually counted the CTR before you have done the cataracts, like extraction, right? So the cortical aspiration is going to be tough. Yes. So how do you deal with that kind of cortical aspiration?
Yeah, I think that's a very tough one. So again, this POPs comes to good use, because once you cause an occlusion, don't pull. You try and detach it posteriorly and try to wiggle it out. When you wiggle it out and there's a fluid wave that passes through the cortical matter in the posterior capsule, you will realize that most often the whole thing comes out. But if you try to pull out centrally without causing a detachment, you will fracture it at the end of the equator where your CTR is holding it in place. And that posterior one is very scary to remove, because then you have to go with low vacuum, try to hold it at the edge. So I think POPs would work very well. I think that's a great idea, Vardhaman. For my next talk, I'll try to get a video with the CTR and a POPs technique.
Yeah, sometimes
for sub-incisional cortical removal also, it will be good. Sub-incisional cortical removal with coaxial eye.
Yes,
it's quite useful.
Absolutely. Absolutely. So what I've tried for those posterior fibers sometime is just trying to use your regular cannula of hydro and just give a small gush with causing turbulence. That has also worked well. But I think this POPs, I think for especially beginning surgeon, if they have to learn the right way, this should come handy, and that will make them get into a right habit. So I think absolutely great demonstration, Samresh. Wonderful. Any other comments from any other?
Yeah, Vardhaman, while you just said about the flushing technique. Now, what I've seen is sometimes accidentally I just happen to, apart from flushing it directly, sometimes once or twice I happened, and then I use it more often, that you have a cortical fiber sticking to the posterior capsule, and sometimes they're very stubborn. And even if you flush it from the main port, from the side port, they just don't move. So I have tried flushing alongside the fiber, a little towards the side, and some kind of Bernoulli's phenomena happens, and then those fibers start moving. So instead of directly targeting the fibers, if you just go a little away from that, It works. It works.
I think that's
And second thing is
Can I add?
always you press the posterior lip. You want the capsule not to be very
Yeah.
convex. It has to be slightly
Yes,
up.
want it to be,
Then
yes.
then your fluid will act better when you flush it. If the posterior capsule is very deep, then it won't work. So it has to be a little bit shallow. The posterior capsule comes a little bit forward. Then you flush. Then it works out very well. And for the CTR thing, no, you just hold it and swipe. You hold and swipe. The tangential extraction works very well when your CTR is there and cortex is there. So you just engage and work around it. So as you said, swipe technique, or I call it tangential extraction, that would work well there when the CTR is
Differential extraction is circumference.
Sometimes I use a capsular polishing parameter. Go down and just detach that small tip from the posterior PCV area, and then shift to a full cortical aspiration. And the other way around, I pull it from posterior towards anterior and take it out.
Cataract mode, you are saying.
Yeah, cataract.
Yeah, Dr. Anga.
Yeah. Sometimes you have very flimsy cortex, then going with the polish mode, little bit detaching it and then removing it would be a good idea. In flats, especially, there is a vertical cut of the fibers. So you will not get those loose fibers. You will have to go underneath the anterior capsular rim. So there also, if you go with the polish mode and just detach it and then loosen it and then remove it, it will be safe. Rather than sometimes you might just catch the anterior capsular rim. And when you're flushing, what we were talking about, it should be done from the main port itself, main incision. From the side port, it can cause sudden, blowout.
There has to be outflow. You're right. Absolutely. There has to be
It should
outflow.
be done from the main port only, not from the side.
Yes, very good tip. It has to be done from main port. Just like hydrodissection, which has to be done from main port. Same thing for hydro polishing.
Absolutely. Yes. Great. Thank you. Thank you so much, Samresh. Over to you, Dr. Bide, sir.
Yeah. So now we have our next speaker, Dr. Amulya Sahu. He's a founder chairman of International Society for Manual Small Incision Cataract Surgery. And we all know that International Society for Manual Small Incision Cataract Surgery has many chapters all over India as well as abroad. And recently they have opened a chapter in United Arab Emirates. And he's one surgeon who will always do manual small incision cataract surgery, and he's a proponent of M6. So over to you, Sahu sir.
Yes.
Yeah, thank you, Santosh and Bardhaman and
thank you, sir.
Anga, for giving me this opportunity. And after hearing all these stalwarts in PECO surgery, now I'm coming to the simple form of life. As you understand, the happiness lies in simplicity. So I'm think that all of us, see, now we have opened 16 chapters abroad, including America, United Arab Emirates, Australia, and Singapore. So all these surgeons who are best in their game, if they take interest in the SICS, it would be good for India and it will be good for all of us. So with that, I would say that the PECO's importance lies in this very small incision. But we started with scleral incision in PECO and we moved to cornea. And all of you know that it's creating a lot of complications, not in the best hands, but those who are beginners. But the sclera is the most secured wound. So I'm showing you 2 millimeter. It has taken a long time. I've modified my instruments to suit my purpose. Now, my video, please. So this is my marker I've designed, and I give the incision the steep axis. I've done thousands of cases. And now Nilutparna Deuri is whom I trained in Shankar Dev. She is putting PMMA lens in these things. And the secret to this thing is the back cut I gave. So there's a 1.5 millimeter behind the limbus. This is a erasing as we used to know. And the skill has to now must be revived. The surgeons they're in a hurry to master the machine. They have forgotten the surgeon and the skill. So the result is it has been published now in IGO. They say that we are not contributing to any astigmatism. So this pocket gives me a lot of space. Now I divide the lens in the AC, in the tunnel, and also in the bag. Now that last thing is that was remaining is to divide the lens in the bag. That has happened, and result is excellent. I told you about this chopper, that is a Jacobi's chopper. You can break any hard cataract with that. I think Deepak has to guide to our video should, my video should improve a little, but after seeing their video now you feel that it is not worth. So this is a modified dialer. With that I nudge the lens outside and I will break it in the tunnel because it was not a very hard cataract. It's a hard cataract, then the incision size has to be increased. Up to grade 4, you can do it easily here, but very hard cataract, 2 millimeters should be avoided. The cortical cleaning is done from the side port. So the carbon footprints you are reducing, your take home increases, your investment becomes less, you are more, you don't create posterior capsule rupture and that kind of problems. So you can either inject the lens or you can put it directly. I'm putting it directly in this, but you can inject, you can give all kind of lenses, high-end lenses. You can charge your price. I think one of our colleagues is charging around 3 lakhs. And he says that he does SICS, so there is nothing. It is the surgeon's confidence. The price is according to the surgeon, not to the lens or anything. So that has to come now. The marketing of the machine should, but it has reached its peak now, it should stop there. Let us master the skill. And if all the rich countries are now looking for this kind of surgery, why not India? And particularly our best surgeons. So that other video. Now if you close the tenons and conjunctiva separately, then your gram-positive negative infection chances are less. And next day you don't see where you have operated. That's now this is here I am showing you. The lens, whatever the hard lens, you can divide it in the bag. So once you do it, you can do it 2-3 pieces, whatever you want, and then flush it out. Okay, I think that's enough.
Thank you, sir. I think wonderful demonstration and the patients, I mean, all our colleagues who want to learn SICS in the right way. I think you are the real brand ambassador maybe for them to make sure that this technique, which is popularized in India, reaches the masses. So I'm just going to stop my sharing here. And I think probably we'll take quick comments from some of our experts. Dr. Gupte, sir, are you here? The other a very prolific proponent of SICS.
Dr. Arup can also comment because he's the one who has been doing SICS for many years.
Right.
If Dr. Arup is here.
Yeah, Dr. Arup
Parikshit is
used to do SICS when we were training in Madurai way back in 1998. But what Dr. Sahu has done is, with his ambition, he has tried to make the 5 mm tunnel into a 3 mm tunnel or even a smaller tunnel. So that really makes it, in terms of astigmatism, almost equal to a phaco incision. So it's a phenomenal surgery, but then it's a surgery that needs a lot of skill and patience on part of the surgeon if we make the incision less than 4 millimeters. So yeah, we really have to be very careful and diligent while doing the surgery. And at the same time, this of course holds true for phaco too. We also have to consider the corneal endothelium, because it's not just the astigmatism that we have to be worried about. It's also the corneal clarity. But if done properly, it gives phenomenal results. And there are, of course, so many publications which show that the results are comparable in both techniques.
Absolutely.
Availability of different minification techniques of nucleus. I think with SICS also, like we have seen Milo by Dr. Keki sir and Dr. Anil Shah's snare technique and all other techniques. So with that, it's quite possible to reduce the size of incision.
Yes, so
I think we have Colonel Deshpande sir also.
2 mm. Yep.
Colonel Deshpande sir is
As
also.
far as I'm concerned, I prefer to listen. But one thing I saw that most of these eminent surgeons were very cool and calm to tackle these sort of situations. One study was done when I was in the army. A Holter monitor was used, and we found, during the complications, the heart rate had gone to more than 160. Dr. Colonel Nath was there, who was eventually he did that study. But those days we didn't publish it, but really worth it if somebody repeats that, because as more important is we ourselves than any technique.
There was one study done in AIOS, and in that even blood cortisol levels were also assessed of the surgeon. Yeah, that paper was there for assessment. I don't know whose paper it was, but they had done that, even oxygen saturation level, heart rate level, and cortisol levels of surgeons.
This time has come now. We have to go out of these clinical things and study all these other parameters. More important is surgeon rather than technique.
Yeah. True, sir. Absolutely.
We all love the thrill, no?
Yeah, thank you.
So, Harshul, what do you do to avoid stress prior to surgery?
Oh, he does so many things. No, I mean,
Let's hear
apart
from
from ophthalmology that keeps him, I think, stress-free.
I think he will sing a song and then go and do this. I think given my opportunity, all of you should do yoga. You all must do yoga, and then you become a very meditative person. Our medium is a meditative medium. There is no, no heroism. Just meditate and beautiful things happen. And all of you have reached that. I think some of you must be doing meditation. Otherwise, this kind of result is not possible. And then Harshul is doing in a variety of ways. Sports, harmonium, singing, whatnot. So,
the right kind of music has to be there in OTs.
Yeah.
Just love the old songs. Favorite songs playing.
Do you step up the rhythm when you have a complication, or you have a way of?
No, when good songs are playing, there are no complications.
Well, if you have had no complications, we're not doing surgery. So that is a given fact.
If you all of you are hearing one thing is that India is going to for last coming 50 years, India's age, and all of you should take meditation to the center as surgeons, because there the Abraham thinking is domination. And for us, it is assimilation, is embracing. So our journey will be totally different than all these top level surgeons, all of you, the next generation surgeons. They should embody the India's ethos and the family value, and then meditation. These things should go with your surgery. It is surgery by itself is a mechanical thing and it's nothing great. But when you carry it with philosophy, and that is something people will look up to you. That is a wonderful thing, and there is nothing to whatever we have to learn from West, we have already picked it up. They are not going to contribute much. But it is here is our time. They will learn, and the way these UAE people were lapping it up. So I can say that there is a demand. There is so much of demand. So you are ambassador. Think like that. I'm little senior, so advising you like this. So yes, pardon me for my indulgence, but I see you as the future India's ambassadors. not as surgeons.
Pandey sir also can contribute his thoughts regarding today's webinar as well as the future webinars. Deshpande sir.
Yes, it is very interesting to listen, and most of the modern developments and the coolly all situations can be controlled. That's very good. At the same time, I agree with it will be very good, interesting to have another seminar on what they do to keep themselves cool. And we'll have many answers, many interesting things will be there. There can't be one answer. There can't be one solution for that. But definitely it depends on the person to person. Yes, experience and surgery itself is a meditation. But the way you get involved in your patient and your technique, I think that you concentrate much beyond, you forget yourself, and that is the best concentration one can have. So there are so many ways, you can have more answers. I think it will be interesting to have a seminar on this type of a thing. What do you do to keep yourself calm, You will have many answers.
Absolutely.
Thank you. It was good for me to revise my knowledge. Thank you very much.
Thank you, sir. Thank you so much. Yes. So I think absolutely it has been an amazing learning experience for all of us. We would like to, of course, thank all the galaxy of our expert panel and the speakers. And to do the official vote of thanks, I would like to invite Secretary of Scientific Committee, Dr. Aditi. Over to you, Dr. Aditi. Yeah.
First of all, I would like to thank all the faculty for wonderful talks and sharing their top pearls in cataract surgery, and obviously top pearls for keeping your difficult situation also. I must admit that all the talks and videos were so much engaging and interesting. Thank you once again for all the faculty, Dr. Kumar, Dr. Hardipurkar sir, Dr. Kiki Mehta sir, Dr. Deepak Megur, Dr. Arup Chakrabarti sir, Dr. I'd like to thank our expert chairs, Dr. Colonel Madan Deshpande sir, Dr. Gopte sir, Dr. Suvin Bhattacharjee, respected President Dr. Bide sir, Honorary MOS Secretary Dr. Anaga Harur Madam for making the webinar very interactive. I would like to thank Endor Pharma for the support and also the team for helping the glitchless streaming of the webinar. Thank you all the viewers from Facebook, YouTube, and Weblink. And last but not the least, Dr. Varman, who has taken a lot of efforts for this webinar. So thank you all once again and have a great sleep. Good night.
Thank you. Thank you again. I think at the end, we would play a video by Entod about their Phenocan, which is a very short seconds video. Thank you a lot to Endod Pharma for supporting this webinar, and of course, I know that they have been very innovative in all their products, and we all have been beneficiaries of all their innovations. Again, I think at the end, I would like to thank everybody, and over to you, Dr. Bide sir, for the final remarks. Yeah.
Before that, our secretary, Dr. Anaga, would like to say something.
Yeah.
Dr. Anaga, please. Dr. Anaga Heru. I think she's muted.
Probably she might be in the train, probably.
Yeah, maybe. So I think it was a wonderful webinar. First of all, thanks to all the faculty for taking out time in spite of their busy schedule and sharing top pearls in cataract. And we are going to have another series, 2-3 more webinars, and looking forward to their contribution in those webinars as well. And as Dr. Sahu sir and Dr. Colonel Madal Deshpande sir has said, we will definitely have one webinar on how to manage stress before going to OT for all the surgeons.
Like
Can
Dr.
you hear
Anaga, yes, Dr. Anaga, some
Can you hear me?
Yeah.
We can hear.
Yeah. Sorry, I don't know, some network connection. Yeah. Excellent webinar, Dr. Vardhaman. And I'm so happy that we have had such a lovely and fantastic pearls of wisdom from all these galaxy of speakers. And I think even those who have not attended also can easily access it on YouTube also.
Absolutely.
You can take benefit of it and go back to it again and again. It will be like a revision class actually. So thank you so much to all the esteemed speakers, other expert panels, Dr. Santosh, and again kudos, Dr. Vardhaman. Thank you for everything. Thanks.
Thank you. Super. All right, I think we'll so
We have a great team.
yeah, absolutely. Yes, and
Congratulations.
special thanks I didn't mention it before is to Dr. Suven sir. Dr. Suven sir had been through a, let's say, a health situation, but it is inspirational the way he has contributed today. It is always amazing to learn from him. And thank you so much. Thank you so much, sir.
Thanks, Vardhaman. Thanks, MS. Thanks, Bidya sir. All of my friends, so I can't refuse turn you down. So thank you.
No, it shows your commitment, Suven.
Yes.
Towards the topic and passion.
Thank
and
you.
Excellent videos, everyone. Dr. Deepak, Harshul, excellent. Kudos.
Thank you, sir. Thank you.
Thank you.
Good night. Good night, everybody.
Good night.